Hello, I'm Dr. John Cruz, and today I'm going to be talking about ADHD and movement disorders. So I'll be talking for about 20 minutes. I'm going to give you the takeaway message at the beginning. And if there are questions, you can type them in while I'm talking. I'll try to get to them at the end of this presentation. And this will be posted both on Facebook Live and on YouTube later. So the takeaway message is that ADHD, Tardive Dyskinesia, and Parkinson's are all dopamine damage problems with dopamine systems in the brain are implicated in all these conditions. ADHD is clearly associated with both Parkinson's disease and Tardive Dyskinesia. Now, the vast majority of people either with Parkinsonism or Tardive Dyskinesia do not have ADHD or have not taken stimulant medications, and we're still sorting out what the nature between ADHD and these movement disorders are. So that's the takeaway. So I'm going to start with a little, and I'm going to try to keep it simple and basic, but some understanding, some basic brain neuroanatomy, and some neurology. So to start with, we talk about dopamine, serotonin, norepinephrine all the time as if most of the cells in the brain are using these neurotransmitters. The dopamine cells in the brain are actually number only about 400,000 cells. That's out of 80 plus billion cells in your nerve cells in your brain. That's less than 1 out of 200,000. To sort of put that into context, if you surveyed the population of San Francisco and every person is a neuron, only 4 people in this whole city would be dopamine neurons. Or if you like a red state analogy, the state of Alaska has about 800,000 people. If you look at the whole state of Alaska and each person is a neuron, only 4 of those people would be dopamine neurons. So these are tiny, tiny systems numerically. They are powerful systems because they start in one part of the brainstem or central brain and spread out and influence whole hosts of other networks and systems. And I'm going to keep this brief and oversimplified, but there are sort of 3 basic dopamine systems in the brain that we're going to be talking about. So one is the nigrostriatal system. So it starts in, this is a system within the basal ganglia. It starts in an area called the substantia nigra, and those dopamine cell bodies project into the caudate and putamen. The nigrostriatal system is the one that's most intimately involved with movement and motor disorders. So Parkinsonism and probably Tardive Dyskinesia have most of what we're talking about with those are talking about that nigrostriatal system. Now, there's at least 2 other big systems of dopamine in the brain. One's called the mesolimbic and one's called the mesocortical. The meso means that coming from the brainstem is where the dopamine nerve cell bodies are originating in the ventral tegmental area. And then for the mesolimbic area, these are connections that are going into the limbic, the emotional brain. The dopamine reward system is that mesolimbic system. That's also a system that's involved in craving and the salience, the importance of different signals in your brain. And the mesocortical system, where it's going from the ventral tegmental area into the prefrontal cortex, is deeply implicated in our executive functions. So our ADHD functions are more often focused or concerned with mesolimbic, mesocortical systems. There are nigrostriatal changes and differences within ADHD itself. One study showed that more than half the kids with ADHD had abnormally large substantia nigras. So all 3 systems are probably implicated in all 3 of these diseases, but we sort of focus more on motor function. So what is Parkinsonism? Parkinson's disease, is the second commonest neurodegenerative disorder, second only to Alzheimer's disease. In Western countries, by age 60, about 1% of the population have Parkinson's disease, about 4% by the time you're 80. So it's something that's age-related. It's much less common before age 60, and the rate goes up as we increase in age. With Parkinsonism, we know that involves the destruction of dopamine neurons in the substantia nigra. And again, there's only about 400,000 nerve cells, dopamine nerve cells in the brain to begin with. So when those die off, they do not seem to make themselves over again or rejuvenate or recruit. So when you lose it, those are gone. So I'm going to be blurring the terms Parkinsonism and Parkinson's disease. Parkinsonism is a broader term. Parkinson's disease actually means specifically that we don't know what's causing the Parkinsonism, so that's a little weird. So there are a few subsets where there's clear a genetic cause, but that's a minority, or sometimes a clear environmental cause. So in the 1970s, there were U.S. government trying to get rid of marijuana crops in Mexico, sprayed them with paraquat, and clearly some people much younger than the typical age for developing Parkinsonism developed Parkinsonism with destruction of the substantia nigra from smoking marijuana laced with paraquat. Again, it wasn't laced intentionally by dealers. It was a pesticide sprayed on it in the attempt by the U.S. government to eradicate it. But in the vast majority of cases, we don't know the specific origin. Again, we know what is going on. We don't know why it is those nerve cells in the substantia nigra are destroyed. The thought is that there are multiple genes contributing to this and multiple environmental factors also contributing. So one other factor, separate from the specific paraquat, we know pesticide exposure in general increases the likelihood of developing Parkinson's later in life. We also know head trauma anywhere in life increases the likelihood that by later in life you develop Parkinsonism. So Parkinsonism is characterized by 4 neurologic symptoms. So there's a tremor, and it's most often earliest showing up in the hands. Sometimes one hand way ahead of the other hand, but eventually both hands. And classically, it's a resting tremor. So when the person's sitting there, their hands shaking. I don't know if you can see that. But when they make a movement, there may be much less tremor in it. So it's different from an essential tremor, which is they're at rest, and as they're moving, they're shaking more and more. So there's medical schools are rife with stories to the first-year medical students about surgeons who are practicing who are sitting there with a resting tremor, but when they're doing their fine motor movements of surgery, are completely in control of their movements and still adept at that. So 3 other movement parts of Parkinsonism. We have the resting tremor, we have rigidity. So the body isn't just limp and relaxed, there's a rigidity in the muscles. That's probably also connected with a difficulty initiating or starting movement, hard to get up from a chair, hard to start walking. So tremor, rigidity. Number 3 is bradykinesia, which just means slow movement. So even when they get up and moving, movements tend to be slower. And an unstable gait. So positioning, it's more than just the movements itself. The feedback, the awareness of what's going on with the body is probably impaired. And again, in addition to these motor symptoms for Parkinson's disease, there are measurable executive function dysfunctions, problems with attention, problems with hyperactivity, problems with impulse control. Some of these may be due to the Parkinsonian medications, which are dopamine boosting medications. Also, psychiatric symptoms can be part of Parkinsonism, including anxiety, depression, hallucinations, sleep disturbances. So what we know in terms of the connection between ADHD and Parkinsonism, and there's one prominent study a few years ago, it's now been replicated in a few other places, but and this is usually, studies are done by looking at hospital records, who in the system has both Parkinsonism and a history of treatment for ADHD. So ADHD seems to boost by about a factor of 2.5, 2.4 in one study, I think 2.8 in another, your likelihood of developing Parkinsonism. So that's measurably higher than the general population is at risk. Again, most people with ADHD do not develop Parkinsonism, and most people with Parkinsonism don't have ADHD. So those numbers actually include a broader range of both cerebellar and basal ganglion diseases. Parkinsonism is the biggest chunk of that. And the Utah study that got the most public attention a year, I think 2 years, maybe even 3 years ago now, not only did ADHD boost your rate, but in their study, having been treated with a stimulant medication boosted your rate of developing Parkinsonism by a factor of 8, so substantially higher. Now, a study done in Taiwan, I believe, did not show any increase for having been on stimulants beyond what the increase already for ADHD was. So we need to do more thorough studies and flesh out what's really happening. So possible connections. It's possible, maybe ADHD in youth or childhood causes Parkinsonism later on. Maybe there's some common genetic origin that's causing weirdness of dopamine systems that results both in ADHD at younger ages and Parkinson's at later ages. Maybe it's that something about ADHD, and one good example would be we know ADHD itself makes it more likely to lead to head concussions, head damage, head trauma, traumatic brain injury. And we know that traumatic brain injury is again, a risk factor, elevates the risk for eventually developing Parkinsonism. And again, with the factor of whether the stimulants are adding to that risk or not, the writers of the Utah study posited it may be that stimulants are causing this increased risk, or it may just be that those patients with ADHD who were actually placed on stimulants, and it was a minority of their patients identified as having ADHD, maybe that was just a marker for those who had more severe, more extensive problem with dopamine systems to begin with, and that's why they were getting the medication, and that's why they were at more risk later on for showing up with Parkinsonism. Now, there's at least a good chunk of research suggesting that one of the possible connections I mentioned is not what's going on. So there's several different studies that can find genetic contributors to ADHD, that can find different genetic contributors to development of Parkinsonism, and so far there does not seem to be much overlap in those genetic conditions, the genes that are predisposing to either of these conditions. So it does not seem that there's some common genetic factor that can lead to ADHD when you're younger, Parkinson when you're older. So these, again, there are genetic influences to both of these conditions. So far, those seem to be separate. So that's what I'm going to say with Parkinsonism and ADHD, and I'm going to move on to tardive dyskinesia. So tardive dyskinesia, tardive means slowly developing, dyskinesia is bad movements. These are bad movements that are the classic definition as a result of treatment, usually for people with schizophrenia, with antipsychotic agents, which are dopamine promoting agents in general. And the observations have been since the era of treating schizophrenia and other psychotic conditions with antipsychotics. So over the last 50, 60, maybe even almost 70 years now, what we've seen is somewhere in the range of 20 to 50% of these individuals treated with our classic old antipsychotic medications over years, many, many years, somewhere between a fifth and a half of those people developed a permanent movement disorder, and those movement disorders were usually rhythmic movements. Those were usually most commonly of the face, lip, tongue's mouth, so movements like that, or tongue thrusting, lip pursing, but they can be whole body twisting, and I can't imitate those as well. They can also be rocking and shaking movement. So if you've seen groups of homeless people clustered in the poor parts of your city or other urban areas or non-urban areas as well, a good proportion of them are probably displaying tardive dyskinesia symptoms. And part of the horrible aspect of tardive dyskinesia symptoms is that classically, once those are started, they don't go away. And until very recently, just in the last 2 years, we have not had effective FDA-approved medications that could treat them at all. Right now, it's getting a lot of attention, and I've had patients coming into me with concerns. So there are other short-term transient movement disorders, movement problems that can be caused by our antipsychotic medication. But recently, with the advent of FDA approval for Ingrezza, Austedo, one was valbenazine and deutetrabenazine. There was an older drug called tetrabenazine that's only been FDA approved for Huntington's chorea, another neurodegenerative, genetically based movement disorder. Tetrabenazine, the generic one, is currently under investigation for FDA approval for tardive dyskinesia, not yet approved. So with the advent, finally, we have drugs that do have some significant substantial impact. These are drugs that are wildly expensive. So Ingrezza and Austedo are $6,000 or $7,000 a month, which is part of why they're doing lots of advertising to to make a lot of money. These drugs are called vesicular monoamine transporter type 2 inhibitors. The short answer of what they're doing is stabilizing the cell vesicle that contains dopamine that then would release it into the cleft for communication between two neurons so that less dopamine is leaking out at inappropriate times and less is triggering presumably the downstream dopamine that's receiving the dopamine signal. Again, I won't go into that in more detail. So again, although by definition almost tardive dyskinesia is something that's caused by antipsychotic medications, that actually, there's a good bit of evidence, is a big distortion of the story. So part of the story, the bigger part, is that people with schizophrenia, even if they have never been medicated, never touched Haldol, Thorazine, chlorpromazine, any of our traditional antipsychotic medications. So studies have been done in communities that don't believe in medication, communities that had not, Western medication had not penetrated, studies in India, studies in rural Ireland even, showing that tardive dyskinesia-like movements are present in somewhere between 10 to 20% of the schizophrenia population. And again, the older these individuals get, the more likely. So there is almost certainly something about schizophrenia itself predisposing to a movement disorder. Very clearly, exposure to antipsychotics at the very best, and not that this is good at all, but the nicest thing we can say is that it makes it show up earlier and faster and maybe more severely. It's fairly likely that it is eliciting it in people who would never have had that aspect of their schizophrenia manifested. The newer atypical antipsychotics, so drugs like Seroquel, Zyprexa, Abilify, and risperidone, generic names, aripiprazole, quetiapine is Seroquel, olanzapine for Zyprexa. All of these newer generation, last 20 plus years, were designed purposely to have less impact on creating tardive dyskinesia and other movement disorders, the shorter term, less chronic problematic conditions. The downside, so when they first came out, the claim was that the rate of tardive dyskinesia with these newer agents was an order of magnitude or 2 lower. So the claim was fewer than 1% of people are ever going to get tardive dyskinesia. The evidence to date is, yes, these are better than the old drugs, but maybe only 2 or 3 times better. So that's a measurable and good improvement, but it's still a sizable minority of people will get tardive dyskinesia on these newer agents. So one or two things I didn't say about tardive dyskinesia. So one good part of it is that even though these movements can look horrific, usually they're not painful unless they start affecting spinal musculature and causing permanent postural abnormalities, but they can be very socially, disruptive, and actually the lack of pain can be a added problematic factor, so that many people with tardive dyskinesia are not particularly aware of what they're doing or when they're doing it. And I've had patients in the office where I've commented, you're going like this, and they'll say, oh, my mouth is dry. I do that when my mouth is dry. And it's been going constantly throughout the session. So getting back to the connection between ADHD and tardive dyskinesia. So in studies, having ADHD does seems to, and this has not been studied extensively because so much of the focus has been on are the antipsychotic medications causing this, on conditions like schizophrenia, but there is a much smaller bit of evidence than from the Parkinson literature that ADHD itself may somewhat increase the risk for developing tardive dyskinesia. To back up half a step, ADHD itself is also correlated with people with ADHD develop at a higher rate than the general population schizophrenia. Again, most people with ADHD do not develop schizophrenia, but they do at a higher rate than about 1% of the population, which is the background rate. So also very clearly, in addition to the antipsychotics triggering the development of tardive dyskinesia, other agents, and particularly other agents that mess with the dopamine system, are risk factors for developing it. And among the stimulants, it's certainly methamphetamine, so street speed, that has been most widely looked at, most widely implicated. Now, meth, particularly at dosages that are being used on the street, people are abusing it. There are studies looking at that. There are correlations or pretty clearly causative role in destruction of dopamine nerve cells and nerve cells. What has not been established is whether our conventional FDA-approved methylphenidate and amphetamine, particularly dextroamphetamine, the active ingredient of Adderall, or methylphenidate for Ritalin, so far we do not have extensive evidence that at therapeutic levels those are causing destruction to dopamine systems in the brain. It is not clear whether these other stimulants haven't been implicated in a role for tardive dyskinesia. There are even studies way back in the 70s and 80s looking at methylphenidate Ritalin to try to see if it can treat tardive dyskinesia. Wasn't found to be effective. My clinical observation is that I've seen a number of people. One is I'm using stimulants much more widely than I am using even the newer atypical antipsychotics, second-generation antipsychotics. But I've seen a number of people, most of them were on a very low dose of a second-generation antipsychotic, but with the addition of a stimulant, that seemed to precipitate or worsen or elicit tardive dyskinesia symptoms or movements that looked like tardive dyskinesia. In most of the people I've worked with, stopping sort of immediately any sign of that was able to halt the progression. But my clinical evidence is that very clearly stimulant use is connected, again, maybe not as high a rate as the antipsychotics, but it can cause tardive dyskinesia. So that's about all I have to say today. I will not be here for the next 2 weeks. I'm not a psychiatrist who takes weeks of August off, but taking my twins to college for the first time. And I will be back just before the Labor Day weekend, and not to belabor the point, but I'll be talking about ADHD and pregnancy then. So I do see there's at least one question. I will read that and try to answer that. And so the question is, aren't they giving agents to counteract the TD? And so I think that question was typed in before I started talking about the VAMT, the vesicular monoamine oxidase, the vesicular monoamine transporter type 2 inhibitor agents. And the second question Andrew asked is, can the therapeutic levels of stimulants cause psychosis, perhaps in susceptible population. So I have a whole talk on that. It's on my YouTube channel under Dr. John Cruz. It's also in this Facebook session here. So absolutely, stimulants, and particularly Adderall, are a risk factor for developing amphetamine-induced psychosis. I'm happy to talk about that more. My personal bias is that that is the worst of the potential side effects from the stimulants, and the one that most of the ADHD experts, I feel, are minimizing and wanting to sweep under the rug and not look at and want to dismiss. So it looks like there's another question come up. Oh, so the other question is, have I ever talked about rejection-sensitive dysphoria? And the answer is yes. So that, again, it's one of the, probably in the first 6 months of, I don't have the schedule here, but again, on both the YouTube channel or on the Facebook Live, there is another 20-minute talk completely devoted to rejection-sensitive dysphoria. What I will say, short answer here, is I believe it exists. I believe it's an entity. I think it's hard to know whether we're just talking about extreme variants of the emotional dysregulation that is a common feature, particularly people with hyperactive ADHD. And I do not agree with Dodson, who's the big promulgator of rejection-sensitive dysphoria, that this is either one, unique to ADHD, or two, universal in ADHD. So I know, as friends and worked with as patients, a host of people with ADHD who are almost particularly oblivious to any rejection. And I've seen a lot of other neurotypical, particularly gay lesbian, but also other neurotypical people who I think have biological reasons that they were treated differently and are very sensitive to that and respond in the exact same ways Dodson discusses for rejection-sensitive dysphoria. I've also written about this on medium.com. So that's all for today. Have a healthy, happy 3 weeks before I see you. I think it's September 3rd on Friday, just before Labor Day. That's all. Bye.